Thanks for joining us again at the Heart.org booth. This is Manesh Patel from Duke University, and I'm at the American Heart Association's 2011, and I have the pleasure of having Dr. William Boden with me today to talk about the AIM-HIGH study. Thanks for joining us.
Yeah, thanks, Manesh. Appreciate it.
Can you tell us a little bit about the background of the AIM-HIGH study?
Sure. Well, I think we've known for decades now that in spite of attaining optimal LDL levels with statins, there's still a significant residual risk that persists in patients who are treated. And that was really the background of why we wanted to undertake the AIM-HIGH study. We postulated that in patients who had optimally controlled LDL cholesterols on a statin, obviously patients who had established coronary heart disease, so this was a classic secondary prevention study, whether in addition to statins, we could demonstrate that in those with residually low levels of HDL would perhaps benefit clinically from the co-administration of extended release niacin versus placebo. So that was essentially the background for the study. It was undertaken as an NIH-funded trial, and enrollment began in 2006 with the goal of enrolling 3,400 patients. We ultimately enrolled 3,414. And this was an event-driven trial, excuse me, in which we had hoped to have a 2.5 to 7 year follow-up with a median 4.6 year follow-up, with a endpoint of cardiovascular death, MI, stroke, hospitalization for ACS, and symptom-driven revascularization. So a 5 composite endpoint that was similar to Jupiter, in terms of our being able to hopefully demonstrate incremental clinical benefit with niacin versus placebo. So what we observed was that when the DSMB met last in this past April, they discerned that there was no benefit of the combination dyslipidemic therapy strategy versus the statin monotherapy group with really superimposed Kaplan-Meier curves. And in addition, a curious and unexpected signal of numerically increased ischemic strokes emerged in the niacin-treated patients. So for the reason that we had crossed a predefined boundary for lack of efficacy, and because of the uncertainty about whether ischemic stroke was a significant issue, the DSMB recommended to the NHLBI that the study be stopped 18 months ahead of schedule. So rather than going to completion, which would have been December of 2012, the study obviously came to an end in May, so at a mean 36-month follow-up. So the primary outcome measure was no different. There were 274 events in the simvastatin plus placebo-treated patients versus 282 in the niacin-treated patients, a hazard ratio of 1.02, and confidence intervals on both sides of unity. All the pre-specified secondary endpoints were concordant with the primary outcome measure, so we were unable to show any directional benefit one way or the other with the treatment of niaspan and simvastatin. I think that the really key point of AIM-HIGH was that 94% of the patients at baseline had been taking a statin, and 76% of those were taking it for a year or longer, and 40% for 5 or more years. So in that cohort of 3,196 patients, the mean starting LDL was 71. We actually got it down to 62 with the combination dyslipidemic therapy strategy, and we increased HDL by 25%, lowered triglycerides by 29%. So niaspan did exactly what we expected it to do to the lipid profile, but despite those significant changes, we could not demonstrate an incremental clinical benefit.
So clinicians hearing this will probably feel comfortable at least understanding that there may not be an incremental clinical benefit.
Right.
How are we going to reconcile the concern over ischemic stroke?
Well, thank you for highlighting that. We did a very, very comprehensive and careful analysis through the summer as we were continuing to accrue events that were going to be reviewed and adjudicated, and we were unable to define any predisposing factors, whether it's a history of stroke, hypertension, atrial fibrillation, medication usage, that in any way showed a causal association between niacin and ischemic stroke. And as it turns out, in the final analysis, there were 18 ischemic strokes in the placebo-treated patients, 29 in the niacin-treated patients. The p-value was 0.11. The hazard ratio was 1.61, but the confidence intervals were decidedly on both sides of the unity boundary. So it was really, we think, a statistical play chance that there was this aberrant signal of numerically increased strokes. And I don't think it has any consequences, because we have not been able to find any previously published studies that would show any kind of a stroke excess. And on the contrary, certain previously published studies like the CDP and a large meta-analysis of all niacin studies, if anything, showed a significant stroke reduction with niacin. So in terms of, I think, the take-home message, I would say the following. If you're a stable, non-acute patient with cardiovascular disease and you can achieve and maintain the kinds of LDL reduction that we achieved, which is the low 60s, then there's no need to treat HDL or to use niacin with the goal of reducing or further mitigating risk.
Well, thanks for joining us. Another very interesting study from you.
Yeah, thanks.